All right. Well, welcome everybody. I am your host, David Mauro. In the studio today is a friend of the podcast and somebody we have a lot of respect for. They are in the trenches of rural America, in healthcare, in IT, and they've exhibited great leadership over the years and driven a lot of really positive initiatives helping improve patient health and care. And I cannot wait to have the interview. Shawn, it is Shawn Weldin, a director of IT at Sabetha Community Hospital in Kansas. Shawn, welcome to the studio, my friend.
Thanks, Dave.
Well, what has been happening in rural healthcare America lately?
A lot of things just kind of moving along as everywhere, with everything going on with the USDA funding, with kind of thing going on at the Fed level, everything is just changing. Nobody knows what's next is always kind of the problem with the big shake on the Fed level. A lot of our funding, people don't realize on the small hospitals, definitely our funding comes from the Department of Ag. Any of those loans we get, the big loans we get from the government for building projects, those big things come from the USDA, which seems like a really interesting spot for healthcare. But I guess somebody had to have it, and it was as good a spot as any for agriculture and rural communities. Made a lot of sense.
So back up a second. So are you telling me, so the USDA, which I think of like the stamp on steaks, right? They're actually the ones that fund a lot of your building development for rural health.
Small rural hospitals, yeah, that's the approval entity for our
really
our loans for like a new building. So
a lot of people may know that. I didn't know that.
Yeah,
so
it's an interesting kind of
holy cow
relationship.
So when they cut that, what type of cuts have happened?
So we've been trying to build a hospital. The building I'm sitting in, as you can kind of tell,
right,
as my office is
older.
This building was built in 1910.
1910, back when I was a kid.
Yeah,
so
back in the good old days.
Yes, back in the good old days.
When this structure I was in, this used to be a waiting room for patients. My office used to be a waiting room. So this area I'm in, right, was built in 1910. The newer half of this addition was built in 1930.
Oh wow! So the more modern is from pre-World War II.
Yes,
that's
outstanding. We jumped a couple wars there. It was nice.
Holy cow!
And then we built a big addition on in 2003. So we have but it's 20 years old now. So as we were kind of looking at that, we've not spent a whole lot of money on our infrastructure. Since that 2003 edition, it's amazing how much stuff it's changed. Think about technology in 2003. This building, running network cables and phone wiring through this is a nightmare. It was pre-iPhone too, so it probably has the state. When you see homes that are older, they always have the stations for the computers. When in reality, everybody's working on computers everywhere. In the new building, we ended up mounting computers in rooms that really were not made for it. We're just kind of tight on space. We've done a great job, and we've done a great job maintaining what we got. But it's this building, the floors are a foot thick concrete, but interlaced steel.
Yeah, do you have cinder block walls too? Or
we don't. They're plaster.
Plaster. Oh wow!
Plaster. The exterior here is brick. So we've got trying to run network cables through these floors, the Wi-Fi through this steel interlaced flooring is just kind of a challenge.
Well, I know with some older schools and some older construction sites, when they have the cinder block walls, it really messes with the radio frequency. So Wi-Fi can't go where it needs to go.
Yeah, it's a challenge, just kind of
maintaining. So you got to run cable, you got to run Ethernet, power over Ethernet, etc. You've got to run those hot lines all over the place.
Yeah, and we've got some closets kind of sprinkled here and there because it's easier to run every floor closet to floor instead of going through this big, huge, thick floor.
Yeah,
everywhere.
Makes sense.
That's not ideal. Same for that. We'd love to run some fiber around here, but if we're going to build, there's no reason to hopefully spend the money on fiber we're going to rip out. So we're trying to kind of maintain as we can, but we're hitting the wall on a couple of things where we need to decide, and we've been waiting for the USDA for quite a while, and we've had some motion here recently. There's been some changes on the level, Fed level now here recently that we're seeing some improvements. So we're hopeful. State senators,
it seemed in the beginning, I've been reading about it because I keep up with things in Kansas a lot, and from what I understand is in the beginning there was a sense by the administration that there was just money bleeding everywhere, and so they just kind of stopped everything. And now they're kind of releasing certain things after they verify, hey, this isn't what they deem as waste. They're looking like if it's going to rural healthcare, they see the need
and they're I know the
loosening
folks
things
at the
up.
USDA are doing their kind of diligence. We're not
Oh
blaming
yeah,
them for
no,
wanting to
not at
make sure
all.
that money's being sent properly, which it should be.
Right.
It's just
Yeah.
we're 3 years into this almost. We're trying to get this kind of approved. We thought, we were hopeful to have this done 3 years ago. So it's just been
Mm-hmm.
a process of submitting questions, and it takes time. Submit a question, got to go through the right people, and then at one point with the buyouts and stuff, everybody left. So we're starting over
Yeah.
with new people and new
Right.
staff that just don't know our story, and so we got to kind of start over from scratch some of them. But
Right.
that's gotten better here. We've had some good motion in the last month on that, so fingers crossed we'll have some positive news here shortly, hopefully.
Oh, that's great. And the plan is to expand. Like you have a new set of land and new plans
So
built out,
we
or are
have
you going to expand on the existing plot?
expanded the existing campus. We've purchased some land. The city had a shop building south of us that we've
Right.
kind of taken in over, so we have that land now. We bought 2 years ago, thinking we'd have it, tearing ground up by now.
Right.
So we've had that. This older structure, we love it, but it's just not a hospital anymore. It's a cool building. It's just, I've got HVAC. We have window air conditioners everywhere. It's, steam heat. It's just not a hospital anymore.
Yep.
So we'll keep the 2003 structure and remodel a lot of it. It's going to get a big remodel as part of this, hopefully, and then add a huge new. We have a clinic downtown that's off site. Bring them on site, and all one kind of campus setup. So that's the plan.
Yeah, unbelievable. So when we think about 2003, when that newest wing or the newest portion of the building was built, things were a lot different then. And when I look at especially healthcare, because it comes up in all verticals, but in particular healthcare, we used to have two versions of our world. Like we had computers, right? We had them back in 2003. We had them in 2010, but we still had, and correct me if I'm wrong, but you live it every day. Like we still had processes. We still had kinetic, physical processes, paper. There was still a way, and it wasn't even just having things in paper versus scanning it and having it digital. It was the processes and the protocols and the ways of doing things. And you were able to do all these things. And should the computers break down, whatever it was, whether it was a cyber attack, it was more rare then, but it was internet outage or whatever, you didn't have the type of impact that you do in the last 5 years. Like we are so dependent on our technology, especially in healthcare. It seems remarkable because we're able to do so many advanced things now because of that, but yet we're more dependent. And when things like cyber attacks happen, we're more devastated because having to go back to pen and paper, it sounds easy, but it's not because nobody's done it.
Used to be.
Like, yeah, nobody has done it. Like the people that are there now are either younger and they have no experience in the actual kinetic world and paper processes, but the processes aren't there. Like the actual way of doing it, right?
Go back to some of that because when we went live with our first health record, and the clinic went live in 2007 or 2006 with our first ambulatory record, which most people did the clinic first. We went live full EHR at the hospital in about 2012. And when the system went down, the nurse was like, "Yay, paper!" And they pull paper out, and they'd be just hopping on it, and it was great. And then we've had that shift now. We had nurses that left the nursing areas because they didn't want to do charting. I don't do electronic charting. I want to go to a different area of nursing. Even internally at that point, like I'm going to go to a different part of the hospital that doesn't do electronic charting. Of course, now everybody does it.
Why is that? Is it too burdensome? Is it too much detail?
Some of them were people that just weren't computer savvy, didn't feel comfortable with it. And so they said, I'm going to go up there where I don't have to. And then, of course, it followed them.
Of
2
course.
years later, they had to. But some of these nurses, and it's the new nurses we have are great, but they've never paper charted. They've never had to. They even from school all the way through everything they've ever had. They're young enough now that most of them, some didn't have school books into their careers.
Right.
They just, everything was online.
They don't know how to write in cursive.
They don't. They don't. And dealing with some of that, here I'm going to give you this stack of papers to chart on, and before the old nurses just, let's get this done. I can make a nurse's note in moments.
Absolutely.
Watch this. And
Right.
now they're like, I will wait and write on this napkin until the computer's back up.
Until the computer's back up.
And then
right.
Until we finally have to say, hey, it's a shift change. You're going to go home. You've got to document something on paper.
Right.
And then we'll scan it in, which they don't want to document stuff on paper. Then they were going to put it back in the computer. We've kind of said, hey, we'll scan stuff in now. But it's just a shift change from the last 20 years.
Unbelievable.
Where we've definitely seen, even the last 10 years, where we've seen the migration to staff that are very, very computer oriented, very computer savvy, which is great.
Mm-hmm.
We're not explaining how to get in your email, how to get into how to do things. Multi-factor is not the big factor to this younger generation, because it's not. They've been doing it. They've been dealing with multi-factor,
and they
should. We train our staff that, hey, if your bank's not using multi-factor,
get a different bank. Yeah, get a different bank.
This is no longer a best practice. It is standard operating at this point.
I mean, yeah, and the way we think about it, there's security on one end, and then there's convenience on the other. And if you're too convenient, you're gonna get ruined. Right. And if you're too secure, then it interrupts with operations.
Well, that's
so really just having that balance, finding that balance. And most of the younger generation has grown up with that balance. They've had it through video games and social media, et cetera, in school.
So. We always had a problem with this. If it makes stuff too secure, it's unusable. That's right. We'll find ways around it. And that's where your security breaches feel like, oh, I didn't want to use this thing that made me sign in 5 different ways. I'm gonna just put it in my personal stuff, and I'll just use my home email to send stuff, because I don't want to mess with my work email. It's too complicated. So it's that fine line of trying to find that balance where it's secure as it can be, but usable enough that staff can deal with because at the end of the day, we're still dealing with people that need to do their jobs. And the same for us, we're very cyber aware as IT people, but having that other side where say, hey, yeah, I can't lock this down so much that's unusable. It's like not having it.
Well, I always think you don't have to, right? Like in an ideal world, it would be great to have everything locked down and then there's but it becomes unfunctional, and it almost becomes cost prohibitive, right?
Yeah, but the truth is we're not even using at this point, because we've got to make it so secure that the staff are finding workarounds, or they're just refusing to use the systems that we have that say, it's too complicated, I'm just not going to use it. So we're wasting money on it because it's not being used anyway.
Right. But the key to me, is just doing enough so that the attackers move on past you. You know what I mean? There's just that.
You don't want to be the low-hanging fruit there.
Yeah, like I always view it as we're at the beach and there's people from our organization, people from other organizations, people from our family, other families there, and we see fins in the water, right? It could be a shark. It could be a dolphin. I'm not freaking sticking around to find out. I'm going to start swimming to shore. And the truth is, we'll never swim fast enough to outswim that shark. But the reality is we don't have to. We just have to do enough to beat that guy. Like, we just have to beat the organizations that aren't doing fundamental things, because they're really, the attacker's mentality is really just low-hanging fruit. Right. They're just going after whatever they can get. They're not necessarily going after your organization or your people individually. They're really just going after the vulnerabilities. Who's got an open door? Who's got an open port? Where can we find those vulnerabilities?
Yeah, it's just trying to do the best you can. We all have, especially in the rural world, staffing's an issue.
Resource.
I'm very lucky in a town where I'm from, where we have several IT people that live here in the small town, but resources and doing more with less. All these cybersecurity stuff, my department doesn't make any money. I'm not a profit generating department, but I can spend money like a crazy person if I have to. We can spend a lot of money really fast.
I will say I've been working with organizations on measuring risk, though, and there is return on mitigation. So, when you invest in a new device or a new technology, that's more because it's cool, it's fun, it's convenient, right? And there might not be as good of a return, but when you're investing in security controls, there is actually a return, because it's not only operating and you're getting the benefit of it, but it's reducing risk. And so if it lowers the amount of cost, should there be an event, or lowers the risk of an event ever happen, that is actually a really measurable metric that can be seen on a P&L, because that money doesn't go out. It's not return on investment, because it doesn't generate new revenue, but it lowers the amount of revenue that has to go out, and that still has a positive impact on P&L,
And a
which
lot
is
of
great.
hearing the IT guys in Kansas a lot is say, we just don't have any money. We don't have any money. We don't have any funding.
Right.
Which hey, I'm there. So I don't get it. We're all there. We're all, there's a stat out there somewhere that the percentage of hospitals in Kansas that are on financial downturns right now is majority of us.
Right.
We don't make
Absolutely.
money. We're all nonprofits anyway, but we're
Right.
not making any money definitely. And just a lot of that is I'm very lucky to have some administration that understands that technology is not going anywhere. Security stuff is only going to get more. Our antivirus costs for a long time were, as part of a larger health group, we can purchase those kind of together and get some better volume. But we went from they more than quadrupled in 1 year because hey, we went from having just traditional AV to having MDR,
EDR.
XDR,
Right.
and it was one of those things where it's like this has worked for 10 years and it's worked, as far as I know, it's worked just fine. We've not had any complaints with it.
It's been
It's
quite
worked.
effective, actually.
Either it's doing a great job or it's doing nothing because we're not getting
One of
much
the two.
stuff out of it. Either it's doing great
Right.
where it's just taking care of it and we're not seeing any issues, or it's letting everything through and we just can't tell. So when we moved to the XDR and the MDR, it's like this is a different animal and the cost is so much more. And I'm very lucky to have administration and some folks to say this is not just the latest greatest fad. This is becoming, or will very soon become, a requirement for insurance. We have to have some kind of next gen. So either we can wait till we have to have it, and every day we don't have it, we now know we need it at this point. We're higher risk. So
yep.
Did I go out that day and check that day? No, I put it in the budget. We talked through it. It became, within the next year, we had worked through it. We're adding more features to it now on next budget cycle. Process of working with your administration a lot is just saying, hey, I know I'm not making us any money here, but one breach, one cyber attack pays for itself. This stuff all pays for itself for forever. If we ever have
exactly
this,
right.
if it does this job once, it's paid for itself. So,
yep. Yeah. I mean, the breach costs for rural healthcare have gone up exponentially in the last 4 years. I mean, it's a lot. So anytime you can reduce that risk or lower the impact, etc., there is a huge benefit, and to the providers too, and to the actual patients. So, rural healthcare, when we were talking about the greater impact, when you think about when rural healthcare gets hit, it could be the only level tier hospital at that level for that patient in a hour travel or a 2-hour travel.
In Kansas, easily. There's several hospitals. There's several counties. Kansas don't have hospital at all.
Right. Exactly. And so you have to, if they're down because of a ransomware attack or whatever, then you've got to literally, when every minute counts, you've got to ship that patient over to another.
And it's also like for a stroke. So, there's time frames of success for a stroke that, having that image sent off to and be read by a radiologist within so many minutes is very critical for a patient's care to know what to give them for anti-clotting and that kind of stuff. And then if we're having an internet issue, we're having a cyber attack, we're just having just downtime in general during that time frame, it can be life or death for a patient. And it's where a lot of us, especially the rural folks, that there's one or two of us. Most hospitals in Kansas have one or two IT people on the rural side, and it's a 24/7, 365
really
solution that we're all working through to keep that
up.
You
guys really, in general, I mean, the burden that is on healthcare IT it's monumental because it really is life or death because we are so dependent on the technology in order to render the medical care that the physicians need.
And keeping the physicians, in communication with, we still fax so much stuff. I would love to have faxing leave my life, but it won't happen anytime soon, I don't think. But we're still fighting faxing to different places. It's just
it is the one industry where fax has just stayed.
That insurance.
Yes. Yeah, you're right. And that's probably why it's still
because we talk to insurance so much, probably.
Right.
But yeah.
That's exactly right.
Yeah, we'd love to. And then that's where the
pretty secure though. I mean,
HIPAA, it's the cheapest, securest HIPAA thing you can get a hold of for most small businesses. It is so funny that we're getting better and better at talking to hospitals electronically.
Yeah.
We're getting better at using the QHINs and the HIEs to say, hey, I can send you stuff over here. I don't have to send you a fax anymore. But we still get a lot of patient records just faxed, or people want them sent to their other hospital in the hospital. We'll just send them to our fax. It's the fastest, quickest way to give them to us, and we'll scan them back in. So it's amazing how much we still do of that.
Yeah. Well, and there's not, I mean, part of that has to do with the hacker mentality. They're not really honing their skills on how to breach fax machines. Like they're busy working on AI and other things today where they could do scale, like they could hit 50 hospitals, right? Not just
my one
individual fax machine they want to compromise. Yeah,
and not work that one patient's record that's probably got nothing other than his
what are they going to get out of
driver's license, a couple things you might want in it.
Exactly, which they could buy from anybody else online. So growing up in rural Kansas, how did you get into IT in general? And you were also involved in law enforcement. So walk us through that. There's some great leadership stories there. I grew up in
a small town, South Topeka, a little bit and I was very lucky to grow up in a town with a nuclear power plant in town. So our town had a very large tax base in the 90s in the east. So the schools were excellent. That's where one thing my parents were both school teachers. So we had a lot of the capital outlay monies to spend on buildings and equipments and that kind of stuff. You couldn't pay teacher salaries, which is dumb as a person whose parents were teachers.
Yes.
But you could build a very, very nice ball stadium.
Right.
Or in our school,
there was infrastructure and facilities being built definitely. And things like that. Right.
And technology was part of that too. We, Coffee County, where I grew up, had Burlington, where I was at, we had one of the first fiber networks in the state of Kansas in the 90s. We could talk to any school in the county over fiber.
That's advanced, actually. That's quite advanced.
I took Spanish over, we call IDL, Interactive Distance Learning. I took Spanish one year. And our teacher was never in our classroom. He was always in one of the other four schools in the morning. And he came to Burlington in the afternoon. So I saw him like the first day of school, then never saw him in person until the end of the year. Because he was always just at another school in the morning, and then he'd come to Burlington to do a couple classes in the afternoon. So we were hooked to the libraries in town, and all the schools were hooked by fiber. So it's very kind of interesting to see that kind of technology growing up in that area. And then with that came every school had a technology lab, but the middle school and high school were fairly new when I was there. So a lot of technology modules on everything from PC repair to robotics to video editing, coding, all kinds of stuff. Anything kind of technology, drafting, that kind of stuff. You had options.
And this was back in the 90s, so this was actually quite advanced. Actually, for back then.
We were very blessed to have that kind of system in Burlington. And both parents are school teachers, and I give my mom and dad a lot of credit for not. They both have masters in education, and I decided school was not I was not the best student. So school was not my everyday love. So I was talking to our guidance counselor. Hey, what do you thought? I thought about tech school. That might be more your alley. And Burlington, if you were a decent student and did half your stuff you're supposed to, your senior year you had 2 required classes: government English. That's all you had to take.
Yeah.
Then you could take,
and the rest you could take as like tech school classes.
Tech school. Yeah. So actually, I drove to Emporia, Kansas, only about 45 minutes away. So every morning, me and about 5 other kids got in a school bus, went to Emporia every day. So I took my first year of tech school during high school. Right. So I was in tech school every morning from 8 to noon, and we drove back my last 2 hours of government English. Then I computer aided, which works in our technology lab, for another hour every day. So that was my kind of kickoff into tech school. I did 2 years, then I did that for my whole senior year. I was gone all morning and did that instead of going back to. I liked it. It was something. I would say the first year of my tech school was a lot of Microsoft Office, and the first semester, which is funny because I already had, Burns, we had good technology, so I already had 2 years or at least 2 semesters of Microsoft Office under my belt. So I went to tech school, and they basically said, "Well, here's your Office 2000," which is when it was Office 2000 textbook, and I said, "Well, I've already done all this." She's like, "Well, here's how to learn Access." And I'm like, "Oh no!" So I did a lot of Microsoft Access for about a semester, which is good. A lot of Excel, advanced queries, that kind of stuff, which is cool.
Right. I'm
Excel is very good at Excel now.
Yeah, absolutely.
And then the second semester was PC repair and that kind of stuff, which I did enjoy. I did much more PC repair and electronics and that kind of stuff. So then the second year was all Microsoft certifications, and I'm old enough now. I'm a network certifications. So I'm actually a certified network engineer. That's worth about nothing anymore.
Well, I don't know about that. It's still a remarkable skill.
So, well, I've pulled netware out of more places.
I
Everywhere
know.
I've started for a couple of years, I helped remove it.
Yes.
And then I'm also a Microsoft certified system engineer as well in NT4O, which that's how long ago that's been.
Wow.
So it was good. It was a really good starting off point for that, where it gave me the basics, the hands-on. That was much more. Now I know my learning style, the hands-on, the labs, that kind of stuff. Uh, was more my learning style, which is great. So that got out of tech school there, finished that up, went to work for Leavenworth County in Kansas for a couple of years as an IT tech. And then got a friend of mine worked here in Sabetha for a controls integrator here in town, and said, "Hey, you want to move back to a small town?" I said, "That sounds like a good time." So here I am, and through them, I worked as the small town integrator didn't need a whole lot of IT staff. There's about 30 people work there. So we outsourced our IT staff, which at the time was me, to businesses around the community as well. If you needed, the city needed somebody, a couple
A
of
shared
ethanol
service
plants,
model. Yeah.
kind of
Like a
thing.
shared
Hey,
service model. Yeah, that's
if I
really
could,
good.
so I guess, a day here, a day there. We got enough. I got busy enough. We hired a second person to kind of work with me to do that kind of stuff.
Yeah.
And the hospital became a customer. They said, "Hey, this is 2004. We're just kind of starting, when I first started working here at the hospital as a contractor, there was 5 computers here. There's an AS400 sitting on my floor, holding my printer up right behind my desk.
Wow.
We started a mainframe system here for that. And then about 2007, they got enough.
When servers were huge and complicated and there wasn't much you can do to them.
Yep. Yep. The
Unbelievable.
AS400 is still sitting here on my floor, holding my printer up. And then about 2007, they started getting, more. I was spending about half every week here anyway. They got more and more computers. And so about 2007, I came over here full time as IT director. So
Unbelievable. That's phenomenal. What how'd you get involved in law enforcement?
grew up in the Boy Scouts, kind of a scouting program. So that's actually how I got to Sabetha. My friend who worked at the integrator was a friend of mine through Boy Scouts. He's actually a leader of ours.
Great.
Met him years ago, and then my boss at the system integrator said, "Hey, you don't know anybody in Sabetha at all, because I don't. You need to get out and do something." I was working 200 hours a month. I just didn't know anybody. I was a young kid, and was working all the time. And so we need to find you a hobby. And so I kind of went through the small town things. Either you can be a volunteer firefighter, which that's nothing wrong with that. A paramedic, volunteer paramedic. That seemed like a lot of school I didn't really want to do. And he was a volunteer sheriff's deputy at one point in his younger years. So he's like, "Hey, you ever thought about doing this?" And maybe we just did some stuff through scouts with the law enforcement. I had good friends. I worked with the Leavenworth County guys when I worked over there doing IT for them. My good friend of mine is the undersheriff of the department back home. So I kind of talked to them, said, "Oh yeah, you got to do that. It'd be good to get back with your community, kind of give back." So about 2005, I went over there as don't get paid, just volunteer time, right around full-time guys, just doing community activities, doing a lot of community service
Paperwork,
work.
filing, probably some. Did you do research? Did you do any
Nope.
help with investigations, or was it more admin related? Probably back then because you were kids still.
It's 100%. Here's a uniform. Here's a uniform. Hop on with these guys, get you certified to shoot this firearm, and then to go help the guys do whatever they need to be done. So I
cool.
As a unpaid volunteer, I was driving around in a cop car, carrying a gun.
Wow.
Getting trained on how to do search warrants. A lot of driving around, just backing up full-time guys where it's like, hey, small town, at that time we had like 5 full-time deputies. So when we had about 6 or 7 as volunteers, that on a Saturday night when I didn't have any kids back then, I'd hop in with him and we'd run around and we'd
do the drive-alongs. Yeah,
do the ride-alongs.
Ride-alongs, I've done those. Yeah, those are
doing
fun.
a lot of that, and doing a lot of just, hey, let's go to tonight's baseball game. Let's go walk around the baseball stadium, or this is the system for the football game. Let's go help out with that, or a lot of that for a couple of years. Playing tackle dummy or dummy for the trainings. A lot of getting I've been pepper sprayed. I'm not pepper sprayed. Luckily, I've been tased several times.
Yep.
But I've been flashbang a couple times in my life, playing
Ugh,
bad guy. Would not suggest. So yeah, then about 2007
don't go do that
in
on the
Kansas.
weekends. Yeah.
Yeah, in Kansas, you can only work as a part-time employee at the sheriff's office as a deputy. You can only work 200 hours a year. You have to go through a 2-week part-time academy. So I had to go down to Hudson area in Kansas and take a 2-week certification class to get so I could work by myself and have a normal kind of
Different
salary at the
hours
sheriff's
and
office.
stuff. Oh yeah.
That was in 2007, so I've been doing that since I've been at sheriff's office now for over 20 years, and I've been a full paid employee for probably 19 of that now, or 17 of that now.
That's
A
phenomenal.
lot of, and that, of course, then CGIS, as part of that, they found out that I was a IT person. So, hey, they were just getting computerized records at that point in
Yep.
2005. So I got
So for
in
the
the ground floor
listeners,
helping them get that.
CGIS, yes, CGIS, and I forgot what the CJIS actually stands
Criminal
for.
Justice Information Systems. Just like
Correct. That's right.
EPHI, it's CGI. So
Right,
it's very similar to.
It's really when you're working in IT and you have access to these investigative reports and confidential information, you are taking an oath and you're trained, and then you take an oath that says like, I will, under penalties of perjury or under penalties of going to jail myself, I vow not to release this stuff and to keep it
It's just like
confidential.
kind of like HIPAA just for cops.
Right. Yep.
We keep stuff in confidentiality. We don't send. It's kind of shockingly similar on how we can't send things
To
stuff
HIPAA.
unencrypted across non-secure lines. We can't. We have to have our data secure where we store it. We have to have certain people
Right.
can only have access to things. We have to have physical security of like, hey, you have to have your
Yep.
server rooms locked and your dispatching areas secure.
Yeah, we have a lot of CGIS engineers on our staff, and
so it's a good pivot of a lot of healthcare stuff. So it's been a good fix of both sides. We're just rolled out multi-factor to the desktop level over there as required by the state here very soon.
Good.
So we just kind of rolled that out here in the last month as we're
That's phenomenal.
That.
Hey, so what any leadership lessons you've gathered up from working in law enforcement and healthcare? Like, what have you seen, or what are some of the traits that you find that really demonstrate excellent leadership?
So you got to be willing to you can't have that my way or the highway kind of mentality. It's very easy to say I am the expert in this and you need to do what I say. And that works in both kind of ways. It's you've got to you got to be able to communicate what you need, articulate why you need it, and also just realize that not everybody's going to want to do things your way. If you can, find that good common ground, say, hey, I know you want this. I want this. Can we find a way that makes us both at least reasonably happy here? And there are lines like this is legal requirement. We cannot do this.
Right. We have
there's
to
a lot
do
of that
this
gray area. A lot of that gray area. It's like, hey, or what can I do today to make us better than we were yesterday? And what can we do tomorrow to make better than we were today? So kind of build on that, both locations, build on that as, hey, as long as you're moving upward, we're making the right direction. So don't get such in the slump where it's like, hey, I want to do this. They said no. What do I do? So we got to find the best thing we can to get us by where we're at today. So,
and communication is really key there, right? Like when leaders explain the reasoning and the context for why this is the betterment, like we're all part of the team. This is better for the organization because of this. Then at least you understand the context. Like
I had a
my frustration. Yeah. My frustration with leadership sometimes is when you get a directive and there's no context and you're like, I'll do it. Yeah, that's fine. I just don't understand why. But then as soon as they explain why, as soon as they explain why, you're like, makes total sense. And then you're able to explain it to your teammates. And then, you know what I mean? And it really helps understanding the context.
I've asked people, give me your, as I've had some bosses before. It's like, give me the problem and I'll tell you what I think is a solution. Don't give me solutions to what you think the problem is. Because how you look at stuff and I look at stuff are two very different things. So
absolutely,
I look at things as an IT person. So
right.
Instead of, as you say, hey, I want you to put this thing in, like, well, that's what that might fix that, but it's not going to fix this, or this. Put this in and fix all these things. And this is, just barely either more expensive or sometimes even cheaper than one you wanted to put in on the long run because of the amount of time it takes to put it in and the amount of effort to put it in. And nothing's more frustrating to an IT person than I'll do all this work and then no one will use it. Because I got told to put this thing in and nobody really wanted. But hey, somebody saw something somewhere saying, hey, that's the next best thing. We need to get that put in and we have to have this thing. Like, okay, I put it in like, oh, none of us wanted that.
Right.
I don't know why we're doing this because it doesn't work right. And like, well, I was just told to put it in. So
yeah,
I got
exactly.
100 hours
And you
putting
don't
this in,
understand the
and now,
context, etc. Yeah, and that is so common. There's so many initiatives that get brought up from a grant or from somebody seeing something that's cool, which brings me, before we wrap up, I want to ask you about AI. So AI is being rolled out in a lot of healthcare organizations.
ours included.
Yeah, I mean, how are you guys implementing AI? I've seen it used where it's being used very similar to, let's say, Microsoft Teams, which it'll summarize the meeting and the notes and give you the highlights, the next steps, the actions, who's responsible for what. It's good to have that all done for you. That way you don't have to rely on my handwritten chicken scratch versus yours, etc. But in the healthcare space, it seems like they're rolling it out for summarizing medical records or charting and things like that, because that could really save time.
So
Is that where you're
we are
seeing
rolling
it?
out? We're rolling out. We have rolled out, and we're about to kind of roll out a second phase of it. I think now because it's worked out fairly well. Everything's still a work in progress. Even AI stuff. It's amazing. When I was at HIMSS in 19, AI was just kind of a trickle of a discussion, and in 2024, when I was there in Orlando, you couldn't walk 2 feet without sitting something AI. And last year, it was a whole pavilion based on AI. So I think we're rolling out we use Oracle Health for our records. So they have some patient. You set the phone down, you open the app up, set it down, and you have your meeting with your doctor, your appointment doctor, and it transcribes the discussion you're having. That's why the first thing we're kind of working through on this is getting that kind of set up. And it's worked well. I think it's still a work in progress. We're having the doctors kind of keep notes on it for now, just because of it is. I wouldn't say it's not accurate. It's just not doing exactly what they want. It's saying what they're saying, but there are some little bit of interpretation to it. It's not making any kind of clinical decisions for them. It's not making any kind of ordering of drugs.
Is it capturing the medical terms? Yeah, is it capturing the medical terms? Okay,
yeah,
good.
It does do a pretty decent job of finding. It's not perfect, and that's why you have to. It says very
much
have to
reread it.
You have to read this thing and make sure because we're using it no different than we used Dragon,
right?
Because
Dragon's been around for years.
And we used it for a long time, and we had some really interesting discussions with doctors where we had one doctor that didn't like the dead man switch. You had to press and hold it, so he wanted an on-off switch, which we did for him until he realized he was setting it down and not turning it off. And we were getting discussion about baseball and all kinds of stuff in the background into this patient's chart. But he realized it 10 minutes later, and there's this, 10 pages of
10 pages of
that he has to go back and delete back out of his note before he saves it. So it does a pretty good job. The future, the things they're showing as an option now are kind of amazing. The stuff they're demoing some of that. We never want to take the doctor out of the decision there, because I don't want a computer deciding my mental health record for me. I want this doctor I'm seeing to decide that for me.
But there's a lot of research that it can do quickly and correlate. It can connect.
My chart.
Right.
And it's like, say, hey, and the new version of some of the EHR stuff we looked at is you would talk, hey, can you show me Shawn's last 5 labs? And are just, here you go. And so him click through and do a bunch of looking and try and remember, okay, your lab was this on this day, and this on this day, was down to here. And you can say, hey, what was the corresponding drop? Was there anything else corresponding with that drop in this lab? Yes, he was on this medication. That results in this. So the features that we're hopefully going to get one of these days will save a lot of time for the providers. That's what a lot of this is the doctors have used this system, say it's not, the charting is still charting. but they're
Yeah,
not staying there
it's
late
still a
typing.
task. It's still a
Yeah, it's still a
time-consuming
task.
task.
They're still definitely involved in it, but they're not sitting at the office at 6:30 at night typing up notes or dictating notes, because when they get done, they sit down, they can review what's been typed for them, correct it, make any additions they want to add to it, and it's done. So they're not spending 20 minutes voice dictating to this thing that's basically doing the exact same thing that the system did on its own, and just in that kind of keyboard time.
Yeah, makes perfect sense. That's excellent. And then you just figure out where the servers are or where they're keeping the data, right? Just to make sure that it's compliant. But I'm sure any organization that is offering something in AI to hospitals has worked through that before they go to market, one would assume.
Yeah, you'd hope. I know with ours, there's supposedly nothing. I'll say supposedly because I have not sit and verified this, but they tell us there's nothing stored on the local device. It's all stored in their cloud. There's nothing. So if someone steals the doctor's iPhone, they're not getting any of that data off of it because it's supposedly not there at all.
Right.
So which sounds awesome.
So that's fantastic. That's really good. Yeah.
But even
so,
that, we're looking at the same kind of system for the nurses, where the nurses can do some of these things. We're getting the nurses where they can have a computer in the room and voice dictate what they're doing. Hey, I'm wrapping this bandage. I'm on the left arm at this time. This looks good. I'm doing this, and it will type all that for them. So they're not. That's a lot of nursing documentation is just reviewing what you did. If you can voice talk yourself through that as you're doing it, and it'll type up your notes for you, and you say, "Oh, yep, I gave this med at this time. I verified it with the barcode on the med. I did. I rewrapped the arm. Looked good. Wasn't any issues.
Well,
Stitches
one would
great.
think it would really reduce mistakes. It would reduce errors. So that will render itself or wind up
when you
being
take
better,
one step out of the
healthcare.
documentation process, you'd hope it would just take taking memory out of things to remember what you did. Because the problem is that our nurses, can get busy, and then it's 4 hours later. They okay, whew, I can finally sit down and chart some of this stuff. And a big trauma, a big ER trauma where they're all hands on deck and they're not documenting stuff. They are writing things on their arms. They're pulling stickers off drugs and things and stick them on their shirts. They can chart it later as they're trying to get this patient coded. If they can just be yelling that stuff out to the system and have it document what they're doing, it's great. So there's some major patient safety and patient staff safety.
I wonder what the next evolution is going to be. Where do you think it's going? Trying to look into the future. I mean, are we just going to have videotape of everything? Like I wasn't at the hospital that day. We're like, we have you on video doing it, but then you have like deep fakes. As an issue.
With law enforcement, we all carry body cameras now. When I first started, that was a thing in my imagination. You never thought we'd all be carrying cameras on us.
But thank God you do, because there's so many. I don't want to say lies, but there's so much misconception to what happened. And then you're able to look at the tape and be like, oh, that's exactly what happened. Like, this is what happened.
We've had car cameras for 20 years. So that's always never been a problem. I didn't ever mind the car camera. I don't mind the body camera either. Mm-hmm. And I've always said it's never hurt me. It's always only helped me. When I got to go back and someone says, hey, argument about something, well, we can just watch the video. It's not a, it's not a secret. It happened.
Right.
It's available if you want to see it. We can pull it up, and it just keeps all of us honest, which is not a problem for us. But it turns this she said, he said, or whatever things into facts, which is nice.
Documentation.
What we know.
That's phenomenal. So every industry has associations, and healthcare has HIMSS, and you're involved in the GPHA as well. What are some of the key benefits that HIMSS offers as an organization to rural healthcare?
So HIMSS, so we're part of the Kansas chapter. Kansas is kind of different because we have 2 chapters in our state.
Correct. One right around Kansas City, and then one for the rest of the state, right?
The Heart of America, or Greater Kansas City, used to Heart of America, Greater Kansas City chapter is the Kansas City and a good chunk of Missouri, actually, kind of around the KC metro area, and we're everybody else. So we're almost all rural. Topeka's in ours, Wichita's in ours, Salina, Hayes, Med, but majority of us, Kansas and Iowa like to play the game of back and forth. Who has the most hospitals and critical access hospitals in the nation? Depends on who closes the least amount of hospitals. I think Iowa may be ahead of us right now, but we're going back and forth on that. And some of the network, I started in 2008 when I first kind of got started as IT director here. they said, hey, there's this group of IT people. You got to get to know them. They meet every once in a while. So I got into about 2008 when I first started at Kansas HIMSS, just as a member, and just got to meet other IT directors throughout the state. The networking's great. We had our big conference we had back in April in Wichita that we had a big discussion on cybersecurity, AI, HIPAA security kind of things going on right now with some of the major changes in the Fed level. Trying to get that cooperation, education, a lot of education. HIMSS has some certifications you can get that are very well known in the healthcare industry as great qualifiers. So it's been I got involved with the board about 2013, I think. I'm looking back as just kind of helping with sponsorships and events, and then I kind of went through the vice president cycle. I think I'm currently for another 2 weeks. I'm still the secretary until our officer elections are going on right now. So I'll be stepping back just into my events role starting in July.
That's great. Well, I mean, to me, there's so much core knowledge that gets exchanged from those engagements because you're able to see, hey, we were thinking of trying this application rolling out. And you can talk to 2 other hospitals that tried to roll it out and it was terrible. You're like, thank you for that, because now I'm not going to die on this hill,
it's like, hey,
right?
We're looking for a new PAC system. Like, hey, who's this one? Oh, it was awful. We really liked ours, or we had a couple of people like, we're looking at something different, but after feedback, we're gonna keep what we got. Everybody else seems to like what we got. It's apparently it's the best thing around.
You from right, yeah. It's and you'll try something that they haven't tried yet, so you're able to relay that. And I just think that overall awareness and knowledge from the collaboration is so important, and the education and stuff.
Yeah, and like so we were in we have some really good there's about 300 members strong in Kansas. Not a lot of those are vendors that join it, which we're happy to have anybody join. So we're a smaller chapter on our level, but we have about 80 to 100 people that are fairly active and want to get involved and want to do things and come to meetings. And the networking is awesome because Dave was at our meeting back in April, and we had around 80 people,
fun.
90 some people.
I loved it. Yeah. I love
good cooperation, good discussions, lots of good discussions. We got to see me in an alien costume.
And I love an event that even though we were presenting at it, like I learned so much. Like I just coming away from the event and talking to people that are in the trenches, seeing it, other people that are helping other organizations in other states. Like it is just so interesting. Like
it's just knowing that you're not alone in some of this, especially in rural Kansas where like I'm for till about 3 or 4 years ago, I was the only IT person here, so it was me. Yeah. So if I knowing like, hey, who can I call and talk about this thing that will understand exactly what I'm talking about, and because no one else at the hospital here until I hired my other guy working for me, would understand. So it's like I need to vent my frustrations about something IT related. I can't. No one else here is gonna.
Yeah, it's good
when we're. And same for HIMSS. We try to do education. We do Cyber Month every year where we do a month-long cybersecurity awareness kind of thing all October every year. And because we always say that when when one of us is smarter, we all are a little stronger because it's
right. Because it levels everybody up.
And one hospital in Kansas gets hit, it affects a lot of us. If a hospital, I'm very lucky to have hospitals kind of close by me. I'm on the side of the state with trees and people on the east side.
Right.
Where I can go to a hospital within half an hour, 15 minutes about every direction. Out west, if one of those hospitals gets hit, the neighboring hospital is going to get it.
It's ours. Yeah.
And some of these, we've had one hospital network that they didn't get cyber attacked, but one they worked with did, and it came over to them through some VPN tunnels.
And they had the burden of it. Yeah.
Yeah, it got into their system. That one hospital got hit, and they had some old legacy VPNs set up for some old records,
and they got in from there.
And it came across the VPN and got into them. So
unbelievable.
And we are such a good collaborator, especially here in Northeast Kansas. We collaborate very well. We work very well with a couple of local hospitals that we share staff. We got a surgeon we share between 3 of us.
Yeah, that's great.
One hospital has a dermatology clinic that they own that we use, and we have another person down that is credentialing for us. All 3 of us use together, so we're very collaborative. It's kind of funny. We talk to different people. I think you guys need to stop fighting. All hospitals, we're very close. We're within a half hour each other. You guys need to stop fighting with each other and start working together. It's like we do all the time.
Yeah, all the time.
I could
That's great.
I could drive over to their hospital in half an hour and walk into their IT guy's room and say hi, and we could just talk breeze for an hour, no problem. It's if I got a problem with sending them data, I got a cell phone and call them up. Hey man, I can't fax you. What's going on? That kind of
That's
stuff.
amazing.
So we're very collaborative, and in Kansas, there's very few hospitals that are kind of because we can't be like that in Kansas. We're all too
right.
We're too nice, but it's also we're just too rural. It doesn't do us any good to have that silo. It's like, hey, I'm going to be my own thing. I'm going to do my own stuff. I don't want nobody else to talk to me. I want to do my own way. It just doesn't work.
No, exactly. Well, Shawn, thank you so much for your time, my friend. I really appreciate it.
Hey, thank you, sir.
We will have links to the hospital in the show notes and links to you and your LinkedIn. If anybody wants to connect with Shawn, you always have good content, good insight. You're definitely one of the subject matter
HIMSS is always
experts.
good research for anybody, or HIMSS in general. There's over 56 chapters of HIMSS around the world, mostly in the United States, a couple in India. But I think if you're ever wanting to get involved in healthcare IT, HIMSS is a good place to start. There's a lot of local chapters, a lot of cool stuff.
Very good. Well, thank you so much, sir. I really appreciate it. And
hey, have a good afternoon.
You too, my friend.